Good morning to you all and welcome to the 8th lecture of the 2020 Palliative Care Lecture Series. Hospice New Zealand would like to thank and acknowledge Cancer Research Trust New Zealand for their generous support and funding to deliver these free lectures. The lecture today will be recorded and it will be available on the Hospice New Zealand website. Please be aware there will be an opportunity for questions at the end of the presentation. We would now like to introduce our guest speaker today, Dr. Sandy Macleod. Dr. Macleod is an adjunct associate professor at the Health Sciences Centre at the University of Canterbury. He is a former palliative medicine specialist with an interest in the clinical management of neurodegenerative disorders, and he has recently spent 5 years in an inpatient dementia ward. Welcome, Sandy. Please go ahead.
Thank you very much for the introduction and good morning. It's a fairly frosty morning here in Christchurch. I thought winter was over. So the topic is palliative care and dementia, and for my second slide I'd just like to introduce the point about the crisis of dementia care. We live in an aging population, and although the incidence of dementia is falling, the prevalence is increasing because of the higher number of older people. In my view, often dementia is medically overtreated. We're short of nurses and carers. It raises issues about medical assistance in dying and the euthanasia issues. And it's obviously very expensive. But one of the elephants in the room is the fact that dementia is a terminal illness, and death is very rarely, if ever, talked about to the patients who are suffering dementia and to their relatives. I thought I'd start with my conclusions, which are fairly obvious, really, that dementia is not curative, but we can modify some aspects of the symptoms and the disorder of the course of the disease. That the management is from diagnosis to death is palliative, that the main carers for dementia are family, particularly family women, and actually as health professionals we only see a very small part of dementia, usually towards the end or early with making the diagnosis. That the care involves a multidisciplinary team of all those professionals mentioned, and that different stages really require different expertise. The Lancet has recently printed this, if you like, graph of the modifying factors for dementia, and if you can get rid of all these factors, you probably prevent or delay dementia by about 40%. Now, it's sort of surprising to me that hearing impairment is at the top of the list and alcohol is at the bottom, because I would have reversed that. I think as a clinician we see alcohol not only causing dementia but certainly aggravating dementia, so I'm a wee bit doubtful about their statistics, if you like. However, it makes the point that we can do a little bit to influence the natural course of dementia. So really what I want to talk about is what are the causes of death in dementia, what's the quality of those deaths, how do we determine that dementia is moving towards its terminal phase? How do we manage the symptoms, and essentially who should be caring for dementia? And firstly, the causes of dementia in the next slide. One of the interesting or troubling aspects is that death certificates are often very inaccurate. And in fact, dementia is only mentioned, according to a British study, in 73% of death certificates of patients who are clearly demented. So the question is really, what's the primary fatal illness? And it's not helped by the next slide, which I'm sorry is a little bit small, but that's a reprint of the New Zealand Medical Certificate cause of death. And in part one should put the disease or the condition directly leading to death. And in my view, this is often misconstrued, and the immediate cause of death, for example, pneumonia or whatever, is listed there, and dementia is listed in C, whereas in my view it should be the other way around, that dementia we know is a terminal disorder and therefore that's the predominant cause of death. There is literature about the cause of death. It's not great literature actually, but Mitchell, who's an American author, reckons that eating problems are 86% of the causes of death in dementia, and febrile illness is about 50%. One can argue about these figures, but there's very limited literature on it. There's a British study that actually did autopsies on demented patients and determined that pneumonia was the immediate cause of death, 57%, and cardiovascular and surprisingly pulmonary embolus in 14%. And just some very recent information, there's a study in a Washington state long-term care facility which suggested that the mortality rate of COVID-19 in their facility was 33%. And Irene Higginson and co in the United Kingdom suggest that about a quarter of people who die of COVID-19 would have died in the next year, irrespective of COVID-19. I think it's important to put that into perspective, that the mortality rate of ventilated COVID-19 patients is somewhere between 60 and 80%, according to the recent Royal Society Journal. So the causes of death in dementia, well, I would suggest that cachexia is one of the major causes, eating problems, if you like. Infections, I'll talk about some neurological causes. Some demented patients fall, fracture their hip, and that's the start of the end for them. I think we make some mistakes sometimes medically, and that maybe contributes. Suicide I'll talk about, and self-neglect. I mean, not uncommonly, patients who are demented, live alone and live in squalor, are rescued by the services, but I suspect that many are not, and many die unrecognised by health services. So pneumonia is often considered to be a very common cause of death in dementia, and certainly the mortality rate in demented patients is probably at least twice that of non-demented patients. Importantly, antibiotics actually make no difference to the mortality with dementia, but they can ease the discomfort. So one of the questions raised, pneumonia is often considered to be old man or old woman's friend, but the question is whether it really is. And the next slide is a brilliant study by Osler in 1896. This is 50 years at least before antibiotics were invented. And he reckoned that no other disease kills from a quarter to a third of all persons attacked. Well, if you say that the mortality rate of pneumonia to a modern doctor is probably less than a third, they would be very surprised. They assume that it's a very fatal disorder. But in fact, as Osler said, it isn't particularly. I mean, it has a significant mortality rate, but it's not invariable, so it's not necessarily old man's friend. And in dementia wards, one very frequently sees untreated pneumonia recovering within a few days without any antibiotics, without any treatment particular other than supportive care. Suicide in dementia. Relatively few patients commit suicide with dementia. There are exceptions. HIV patients, particularly in the early stages, although that has changed a little bit now because it's a manageable condition. Huntington's disease patients are probably the most at high risk for suicide. They come from families where they've seen or observed other members of the family suffering this appalling disorder, and particularly in the early stages, like soon after diagnosis, suicide is a significant risk for them. It may be that impaired competence is protective against suicide. Certainly if the person who has dementia is also depressed or uses alcohol, the risk is increased. And the intriguing question really is, with earlier diagnosis, which we're obviously interested in doing, when patients have their insight intact, will the rate of suicide and dementia actually increase? And I suspect that it may. And certainly anecdotally, we can think of a few cases locally. The next slide, I just want to talk about the possibility of neurological death. in dementia, I suspect that the atrophy eventually hits the basal ganglia, the brainstem, and it may be that it just stops the respiratory or cardiovascular system, and that's why some of these patients just die sort of half unexpectedly overnight, and they don't clearly have any other obvious risk factors such as pneumonia. And there are a couple of names that people, I can't pronounce either of those two names, but they're names that are sometimes used in the literature. So I suspect that we don't recognize the neurological death associated with dementia as often as we should. So the next slide is, the obvious question is, well, what is the quality of the death of many dementia patients? The next slide suggests what the symptoms are in the last couple of weeks, and these are quite surprising really, that half demented patients are in pain, at least a third of them are significantly agitated, and a third of them are dyspneic. We'll come back to the possible causes of the dyspnea if you like. And the other disconcerting factor there is that in the last 3 months of life, many of these patients have undergone at least one burdensome intervention. Incidentally, that's an American study, so it may be slightly different, hopefully, outside of America. So that's another slide. I forgot where the reference was, I'm sorry, suggesting much the same. So what are the signs and behaviours of the dying with dementia in the next slide? And I think one notices that patients get weaker day by day. They become increasingly drowsy, and it's important to note that most demented patients are incredibly fatigued, and mostly on dementia wards, patients are sitting around or in bed asleep most of the day. Unfortunately, they sometimes wake up at night, and that can be problematic for the night nurses. So these patients become increasingly drowsy, increasingly bedbound, increasingly dependent on others. They may shut down peripherally when their respiratory function fades. They're likely to refuse food, fluid, medications. The next slide is an attempt by some Israeli researchers to quantify suffering. They used whatever the mini suffering state examination is and determined that suffering was really quite significant. And yet a European study would suggest that relatives would rate the deaths as being peaceful in at least half of the demented patients or their demented relatives. The other, if you like, philosophical question about death and dementia is, when does death occur? There's a social science literature which suggests that really when your brain is no longer functional, then you're essentially socially dead, that you've lost your personhood. And they talk about death in life. So in some ways, it depends how you, if you like, define death in dementia, whether it's physical or holistic. So the next slide, really raises the question, is it possible to die with dignity with dementia, or is that phrase an oxymoron? The next slide is a picture of Cecily Saunders, who of course said that how people die remains in the memory of those who live on. And this is very relevant in dementia, which can be a very difficult and protracted and awkward death, particularly for the relatives who have sort of half lost their relationship or mostly lost their relationship with the person because of the disorder anyway. And there's a lot of ambivalence and confusion around the death for the relatives, let alone for the patient. The next slide is, when does advanced dementia become terminal dementia? In other words, when does this ultimately terminal illness turn into an immediately terminal illness? And there's a lot of factors here that I can't really go into in view of the time, but we know that the younger onset dementias have a more rapid progress. Some dementias are very much more difficult to manage and have a lesser expectancy than others. Probably the most difficult type of dementia to manage is that of Lewy body dementia, which is associated often with Parkinson's disease. Vascular dementias can be difficult, and of course they have vascular risks, so they can die quite suddenly of cardiovascular complications. Most demented patients are elderly and may well have comorbidity, which may be an influence. Cerebral reserve is really very interesting because those who are of high intellect usually present later with their dementia because they've been able to compensate for the losses. And they may well live longer, although they tend to spend less time in healthcare services because they have presented late. Social support's probably very important. Alcohol, as I've mentioned before, and of course what sort of health services one has and how one accesses those is quite important, because if there's no healthcare services, then demented patients, particularly those who live on their own, will have an abbreviated life. The clinical course of advanced dementia, well, look, it's about the same. The 6-month mortality is about the same as metastatic breast cancer, which is sort of surprising, that patients who end up in nursing homes, dementia care residents, have a very poor prognosis over 6 months to a year. And we often forget that. So the next slide shows the predictors of death in dementia within 6 months. And in a way, I've all sort of covered this already, that those who are not on their feet, who can't converse and relate, who are entirely dependent on care for activities of daily living, who've lost a lot of weight and are cahexic, who have lots of infections, and probably in dementia the immune responses are blunted. Such patients may, because they spend a lot of time and have multiple pressure areas, they fall and fracture their hip, and they may have pneumonia. The next slide is very concerning to the health services, that over recent decades, more and more patients with dementia have been dying in care, either residential care or hospital care. And in fact, Keed in 2001 in Britain suggested that 76% of people with dementia then at that time die in institutional care. And Sampson in 2006 wrote that most people with dementia die in hospital, this is in Britain, and on acute wards. 25% of acute medical ward patients have dementia. Now, it's really hard to think of a worse place to place a demented patient. Perhaps ICU is probably worse than an acute medical ward, but they're awful places. They're essentially very exciting, stimulating, and a terrible, terrible place for a demented patient to be. And yet, as we say, many patients increasingly die in hospital care. So if we move on to symptom management in advanced dementia, I'll start off with more straightforward symptoms, if you like. Nutrition and dementia. Patients have problems eating. They lose their appetite, they don't feel hungry, they can't swallow easily, and they have cachexia, which is very difficult to treat, as those dealing with oncological palliative care are aware. And a cachexia is often not recognised as a symptom of dementia. If the patient's also depressed, they're not very interested in food, and institutional food isn't appealing to some. And difficulties with olfaction and taste are quite common early symptoms of dementia, and interesting, have also been noted in COVID-19 patients. The next slide, artificial nutrition and dementia. Really important to realise that tube feeding doesn't improve survival and is associated with a lot of harms. The loss of having to eat with other people or sharing your meal, There's an increased risk of aspiration pneumonia and infections in the PEG sites. This applies to PEGs as well as to nasogastric tubes. It is appropriate if the dysphagia is temporary, but of course the dysphagia isn't temporary in most forms of dementia. And the other issue here is that many family presume that dehydration is rather unpleasant, but I think there's a sufficient literature now to say that terminally ill patients who are not very active also don't experience much thirst, and in fact dehydration makes management of these patients easier, from a nursing perspective anyway. Breathlessness, as I say, it's a sort of a surprising symptom in terminal dementia, and the question is why and what can one do about it. If they're cyanized, oxygen, but then keeping an oxygen mask on a demented patient is extraordinarily difficult. Probably the management is as in other aspects of palliative care. A whiff of morphine is probably as good as anything else. Benzodiazepines can help, but that increases your falls risk. Incidentally, the reference there from Eiselman who is part of Ray Volz's group in Cologne. That's an excellent overview of palliative care and dementia. So what's the cause of respiratory failure? Well, as I said before, fatigue is a very common symptom when your brain is injured or not functioning. And I wonder if these patients just get so tired they can't even breathe regularly and reliably. And as soon as that happens, of course, they get infections and other problems. The next slide is partly an aside, just to say that resuscitation in demented patients is essentially futile, it's undignified, it's associated with harm, and it's incredibly unlikely to be successful. 1% of residents with dementia discharged alive from hospital following CPR. So unfortunately, the default position, particularly in the hospital I work in, is that patients should be discussed. You should have a discussion with patients about resuscitation. I think that's inappropriate in demented patients. The only reason, in my view, they have CPR training in a dementia ward is to try and save the staff or the staff or the visitors if they would have a heart attack, which hopefully is fairly unlikely. As I've said earlier in the next slide, pain is quite common, 50% of demented patients. And we do know that with increased cognitive impairment, there's a decreased chance that your doctor will provide you adequate analgesia. And the next slide indicates that it's almost accepted by many elderly people that they will have pain in later life. And they often sort of accept that, and they often don't use the word pain. They talk about that they're a bit achy or a bit sore, a bit discomfort. It's very important to get them to elaborate on that, because often they have a very stoical approach to their suffering with pain. So the problem with pain is that their pain tolerance in dementia is enhanced, but the threshold isn't. So it's really how they express the pain, because they can't express it verbally very often. Self-rating scales are quite difficult to interpret, so one's really reliant upon facial and behavioural indicators of pain in demented patients. If they appear to be grimacing, for example, that's pretty obvious, but if their behaviour suddenly changes and they become rather irritable, agitated, or wander, or unusual behavioural repertoire for them, then it's important to consider that they may be in pain. The next slide is really a repetition of that. What are the causes of pain? Well, many older persons have arthritis, constipation, infections. They're just frailty, really, and they're frightened by what's happening to them. They've lost control of their destiny and their dignity, and they're not coping with the discomfort that previously they used to sort of managed somehow or other. There are a variety of rating scales. I'm not a rating scale person, but some people are, and that's the one that is probably the most useful. But it's important to give generous analgesia to demented patients if you think that they may have pain. And in my view, the neuropsychiatric adversities of opioids, for example, are unusual and grossly overrated. Usually they're very well tolerated at low dose in the frail and elderly. And just to make the point that some of the things that we do routinely are actually quite uncomfortable. That's a rating scale out of 10, and putting a nasogastric tube down is nearly a 7 out of 10. Even taking blood is nearly 5 out of 10. And even taking vital signs is perhaps 1 out of 10. So that these things are uncomfortable and can induce pain. And one has to really determine whether or not they're necessary. Is there any point in taking a blood test in a demented patient when you're not necessarily going to do anything about the result? As I say, nasogastric tubes are really not indicated. Sometimes urethral catheters certainly are and can be very helpful. But it's important to just be aware that little things we do can be very uncomfortable for the patient and unnecessary. So I'll move on to the area that I'm sort of most interested in, really, is the neuropsychiatric symptoms of neurodegenerative disorders. And these are really the symptoms that cause us most grief and difficulties as staff. The next slide, I ask a question of you. Have you ever been asked by a sufferer of advanced dementia for a hastened death? There was a period when I was asking patients in the ward essentially what they thought of the quality of life and whether or not they'd like it terminated. And the response generally is an aghast, really, that patients are appalled that you would ever consider this, let alone ask the question. And this is a really important issue in dementia care. The next slide, I refer to the will to live. Some, or many relatives, some staff and some carers assume that the quality of life in advanced dementia is poor. But in fact, dementia patients don't perceive it as such. Very few complain of their disgust with life. And the question is why that is. Is it the disability paradox? Like we fear to be tetraplegic, but in fact we know that if we do end up tetraplegic in an accident, within 5 years or so, most tetraplegic patients are delighted that they have been that they are surviving. So that's the disability paradox. When you actually get the disorder that you most fear, often your ideations about the disorder change. Or is it just the neurological loss of insight, agnosia, that they don't really appreciate? Or is it that patients who have brain injuries and brain impairments become animalistic in their view and their will to survive? And it really raises the question about advanced directives in dementia. Are they valid? I gather in some European countries, if you have an advanced directive and then become demented, that they're quite happy to presume you have competency about the question. And this comes very relevant in euthanasia legislations. Incidentally, dementia is a contraindication in the proposed New Zealand law. So what are the neuropsychiatric symptoms? Well, they occur in 100% actually. The literature says 90%. Many patients become agitated. Delirium. If you've got a compromised brain, you're very prone to having further impairment if you are toxic on some insult. Aggression is a problem. Sometimes that's reactive. For example, a nurse trying to shower a patient and they get angry. sometimes it seems to be more proactive, that for some reason they dislike a particular other patient or a particular staff and actually plan assassination. Depression, obviously. Psychosis, particularly difficult in Lewy body dementia, which, as I say, is really the most challenging of all the dementias to manage. Behavioural regression, disinhibition, sexual disinhibition, aggressive disinhibition, childlike dependency. Some patients become very apathetic, fatigue, lose their insight. Rejection of care is a major issue for the nurses. Patients don't want to eat, don't want to shower, they don't want to be shaved, they don't want their teeth to be cleaned. As I've alluded to before, some patients have a reversal of their sleep-wake cycle. They're asleep during the day, and at night they cause mayhem to their night nurses. So how do we understand the neuropsychiatric symptoms? And in my view, one has to have an appreciation of the brilliance of Jackson, who was a British neurologist who's been incredibly influential, not only to neurology, but also to psychiatry, because essentially Freud stole some of his ideas about regression. So Jackson considered the central nervous system evolved on an evolutionary principle. And when you have an organic injury to it, it regresses or relapses to an earlier level of functioning which it can cope with. So that it behaves more primitively, so that's why you get, say, for example, disinhibited behavior. Jackson also said that when you have a loss of cerebral competency, the brain and the central nervous system tries to compensate by having positive compensatory symptoms. And I suppose the best example of that in a way is that with delirium, for example, hyperactive delirium, you have the compensatory symptoms, whereas in more severe deliria, you have loss symptoms, and that so they become hyperactive and apathetic. So that's an example. In milder forms of delirium, you get the florid psychotic symptoms and the behavioural symptoms. But as the disorder becomes more severe, the brain isn't able to be compensatory in that way, and therefore becomes very passive. In the next slide, I tried to I've got that wrong. I tried to sort of delineate some of the loss symptoms and some of the compensatory symptoms. So if you flick through that list, it's fairly obvious that the ones on the left are loss symptoms. They're symptoms that the person can no longer perform, if you like. And the compensatory symptoms are symptoms that the person's evolving to try and overcome symptoms on the left, if you like. And those are the symptoms that really trouble us. Confusion, aggression, agitation, impulsivity, disinhibition, wandering. It's really interesting that walking and being active is a way to try and soothe our central nervous system, which is why we like doing exercise when we're well. And demented patients do it as well, but of course they wander and get lost, which is why most dementia wards need to be locked. Paranoia, psychosis, hallucinations, jumpiness, sundowning, they wake up at night. And I think included in those compensatory symptoms, perhaps a rejection of care and enhanced will to live. And I think if you sort of conceptualize the neuropsychiatric problems in Jacksonian terms, it makes some sense, and it gives you an idea as to what you should be targeting. Because in the next slide, it says the aged and damaged brain doesn't have the plasticity to allow anatomical or functional repair. So that really there's no way you can reverse or treat the symptoms of loss. The next slide talks of the management of the loss symptoms. really the only thing that we can do is to do the function that the person has lost for them, which is what the nursing staff kindly do to these patients. And that involves a degree of maternalism or paternalism, I think, which is appropriate. The environment has to be simple, safe and secure. A very complicated environment like an acute medical ward is extraordinarily difficult for dementia patients to cope with. Family need to be informed why they need to be in a safe and secure place and why the nursing staff need to shower them occasionally and feed them occasionally. Pharmacotherapy isn't particularly useful. Getting rid of medications is very important. Why are patients with dementia on statins? Why are they on antihypertensives? Occasionally thiamine for alcoholic dementia may be helpful. Melatonin, arguable. Certainly the cholinesterase inhibitors and psychostimulants, which are sometimes used in the early stages of dementia, can be effective in the early stages, but really just accumulate side effects in the latter stages. So when it comes to the management of compensatory symptoms, obviously one needs a safe environment, attentive nursing care, preventing falls, treating delirium very actively, and that's another topic that I won't go into this morning. Pharmacotherapy. What's the role of pharmacotherapy in advanced dementia? Well, if a person is psychotic, paranoid, dangerous, then it's appropriate to trial an antipsychotic. I'm a believer in antipsychotic treatment of delirium, despite the more recent and controversial studies on this subject. There is a literature that would suggest that major tranquilizers can ease aggression to some extent, and that's important. Why should other patients in the ward get assaulted? Why should nursing staff get assaulted? Why should doctors get assaulted? Why should anyone get assaulted when we do have treatments that can possibly help that? But of course, all medications have side effects. SSRIs, sometimes used, can sometimes be effective for agitation and for sexual aggression. They can make men impotent, which can be an advantage in their care. And of course, you can block the testosterone if needed. I think low-dose opioids and benzodiazepines can be surprisingly effective for agitation. I would rationalize that by saying we know that opioids are very effective for, if you like, acute physiological pain, but I think they're also of some effect for acute psychic pain and the distress associated with having a failing brain. However, antipsychotics have a bad reputation in dementia, particularly in Britain, where they're trying desperately to reduce their use, which is reasonable to some extent. But I would also suggest that it would be helpful for the authors of those papers to spend a few nights in a dementia ward where we have very limited abilities to manage some of the really florid and actually very dangerous symptoms associated with psychosis and aggression and dementia. I've been assaulted several times in my managing of dementia patients, and any nurse who works in dementia care will also reveal a number of assaults, I suspect. But of course the problem is with antipsychotics, they increase the stroke risk slightly and they increase the mortality. But it's also a risk-benefit really. Not only for the patient, but I think also for the staff and the relatives. Probably quetiapine and olanzapine are the safest. Risperidone is the only one that's actually registered to be used in dementia, but it tends to have a lot of Parkinsonian side effects, as does oral haloperidol, but not parenterally, and I'm not averse to using parenteral haloperidol in Lewy body dementia. So the management of psychosis and those behavioural problems is extraordinarily challenging in dementia wards. If all fails, we move on to the next slide, and I don't think there's any indications as to how one should approach palliative sedation. In my experience, probably the occasion where it's most used is in those with very intractable and difficult Lewy body dementias. It's probably controversial, needs to be discussed with the family. The staff need to be in agreement, preferably if the patient has indicated that ahead of time that they wouldn't be averse to being sleepy. That may be helpful in making the decision. But I don't think that there's any literature to suggest what the actual indication should be for palliative sedation in demented patients. So the next slide, and we're moving towards the end, you'll be relieved to know what should or could be provided for the care of the terminally ill patients. There is a couple of equivocal studies about specialist palliative care teams for dementia. One North American, one British, I think. Pretty equivocal. The current is we have wards, like we have very good functional ward in Burwood Hospital, a new ward, a big ward, room for people to walk around in, very competent nursing staff, but it's only got 20 beds, and there'd be probably 100 patients in Christchurch who could do with their services today. So that's really not going to be a feasible option unless the health services suddenly become rich. Educating the workforce, well, that's very important and should be done. And probably that's the most likely solution, if you like, is to improve the education of those who work in residential care in all settings and all severities too. So family, multidisciplinary health professional care, education of workforce and residential care in hospitals, or if necessary, is probably the obvious answer to what should be provided. As far as education is concerned, Jane Brinkett's classic book has been redone with a feature on the management of advanced dementia, and that's, I think, freely available. So, moving towards conclusion, what is the palliative management? Competent comfort cares, allow natural death, plus or minus palliative sedation. So essentially, as it is in the rest of oncological palliative care. So what's the relevance of that wee insect there? It's a cicada. And the next slide reports the ancient Greeks were onto this really. The myth of Tithonus, who was a lover of Eos, the goddess of dawn. And she laments that she will outlive her lover. She asks Zeus, who was a more important god, that he be made immortal, but she forgot to ask Zeus if he would make him eternally youthful. So of course what happened was that Tithonus lived forever. He became, next slide, he became brittle, his mind deteriorated, speech became a mere babbling. But importantly, Eos doesn't abandon him. She stays with him. Presumably she didn't get old because she was a goddess of some sort. It was only he that got old, but she didn't abandon him. She turned him eventually into a cicada so that no one will fault his mindless chirping and fragile body. And perhaps that's the humanitarian approach to dementia. And my final slide is to repeat the conclusions, really, that we've got to see dementia as a terminal illness. We've got to manage it palliatively. We've got to support those who predominantly care for them, which are the family. We need multidisciplinary, highly functional teams, and we need more education and expertise about the topic and how to manage it. So my final slide is thank you. No particular closing remarks other than to say that, it's a very challenging area to work in. You learn a lot about human life and humanity working with dementia patients and their families, because you spend a lot of time with families. It is a crisis. I don't know what we're going to do with it, but my generation are living longer, and because generally speaking we're fitter, which is probably the reason why the incidence of dementia is falling in the community. But because there are more old people, there are more dementia patients. And then the other point I'd make is that this isn't just a Western world problem. It's occurring throughout the world, in China and India and everywhere, really. So one of the huge crises in medical care is what are we going to do with dementia? And I think probably Tithonus or EOS was right looking after Tithonus the way that she did, but I'm not sure that general society is on the same page as EOS. So I'll conclude with that comment. Good morning.
And on behalf of the Hospice New Zealand and registered sites, we'd like to thank Dr. Macleod for sharing his time and knowledge with us this morning. Thank you for everyone for listening today. We hope you have found this lecture interesting and informative. Have a great day.